and good afternoon. It's Dr. Duke Majan at the Duke Spine Institute. And we are here today with a patient who has a herniated disc at L5-S1. She has bilateral leg pain, back pain that's horrible. She suffered for 20 years since she was living in Vietnam. And now she's here to get fixed. Are you comfortable?
Yes.
All right. Any pain?
Are you having any pain right now? No.
Now we've gone in with the needles. We've accessed the 5-1 disc. How bad is that on a scale of 1 to 10?
8, 9, 10.
How high did it go? 1 to 10. What's the highest?
10.
10. Is that where you get your back pain?
Is that where you have it? Yes.
Other side. All right. Well, we've just confirmed that 5-1 is the source of her back pain. I'll put it on the other side. Are you comfortable now? And that is concordant. So 5-1 is a 10 out of 10 concordant. How bad is that on a scale of 1 to 10? Knife. 10? All right. You can go to sleep now. When you wake up, that pain will be gone. So she has an MRI that demonstrates two bilateral tears at L5-S1 and a large kind of central paracentral disc herniation shot. You may have the wrong MRI up there, Henry?
I believe so, yeah. I took it down.
Yeah. So we've just confirmed through the injection called the discogram that indeed she has pain coming from 5-1 knife. I made the incision a little bit too small, about 6 millimeters. I need to open it just a little bit more so I can get my tube in. She's going to sleep right now. When she wakes up, we'll be done with her surgery. We're going to fix both sides at L5-S1. Just moving just a little bit. Is she all right? Well, I don't know that she needs more medicine. She may just be, reflexively moving. Shot. So I'm going to numb her up a little more. I'm bringing the dilator down to the 5-1 disc. Shot. The dilator is sliding along the guide wire. I want to keep an eye on the guide wire. You can actually see the herniation there. You guys see it? Show us, Jordan. Gosh, all these crisscross things just suck. Yeah, good size herniation right there. Okay. Shot. Now we're pushing the herniation back into the disc. There's a big tear. I can feel it. We're just underneath the exiting nerve root. This herniation was causing two things: horrible back pain, called discogenic back pain from discitis, which is inflammation of the disc. The second thing it was doing, it was irritating her nerves. That's it. Going into her legs, causing leg pain. Okay? Shot. Out. So we're going to go on both sides. We're going to start with her left. Any questions?
No current question.
All right, let's go ahead and show the audience why these annular tears cause so much back pain. This discitis, how does it work? All right, you see now how the annular tear and herniation cause inflammation called discitis, and that's what causes all the back pain. This is a lot of scar tissue right here around the herniation. The blue is the degenerated nucleus pulposus. The gold color is calcium, called dystrophic calcification. It's associated with abnormal tissue, chronic inflammation, basically a pathological state of tissue. Definitely not normal tissue. Any questions?
No current questions.
All right, our last patient's doing well, and he's going to be going home any minute now. This patient is having outpatient surgery at Duke Spine. The IV pole is like right in my line of sight. I don't know why. Let's lower it just a little bit. Thanks. Everything good? Look at that inflammatory tissue there. All right, let's show our second video, which shows how the Duke laser disc repair cleans up the tear, eliminates discitis. All right, welcome back. You now see how the Duke laser disc repair works by using a laser under endoscopic guidance to remove inflammatory tissue and herniated disc, calcium deposits, all that stuff that's stuck within the tear in the back of the disc where the pain comes from. By removing this stuff, debriding it, we're able to get rid of the source of pain and eliminate people's back pain. There's more than one source of back pain, of course. Back pain comes from discs. It also comes from facet joints. It comes from the SI joint, the piriformis muscle. So any of those could cause back pain, chronic back pain. It's very important that you and your doctor figure out what's causing your back pain. Everybody's back pain is a little bit different in terms of exactly where it comes from, but the sources are all the same. It's disc, facet, SI, piriformis, sometimes coccyx. That's the common causes for degenerative conditions, degenerative spine. It doesn't include trauma. Trauma is different. Trauma is a motor vehicle accident or slip and fall. You know, in those types of situations, the cause of pain could be fractures of the bones. Any questions from the audience?
No current questions.
All right, just to remind you, we're at L5-S1. This is the L5-S1 disc herniation, and that's all scar tissue right there. You're looking at a wall of scar tissue. Remember, this patient's had back pain on and off for 18 years, 20 years, maybe longer. She injured her back a long time ago. You guys see all that? That wall of scar tissue I'm working on right now with the laser. That scar tissue is caused by the herniation. The herniated nucleus pulposus causes inflammation. That's what makes the scar tissue happen. Chronic inflammation. You don't get scar tissue from one week of inflammation. You get it from years of inflammation. Maybe you know somebody who's had acne on their face, right? Folliculitis, which is inflammation of the hair follicles on their face. That causes pimples, right? Well, if those pimples stay for years, then they get scars. Scars or pits. It's no different with the disc. You're going to get scarring inside your disc. Grabber. You know what I want is Grabzilla.
Jordan, can you take over laser for now, please? Until Oscar came back.
I'm going to try to grab some of this out with Grabzilla. Scope off.
Lights on, please. Thank you.
Let me introduce you to Grabzilla. For those of you who don't know Grabzilla. Grabzilla, look at the other grabber that we use, much smaller. Let go. I want to show the disc material. You guys see that? What a difference, huh?
Yes, we do.
And you can see a little bit of herniated disc right there from the other one. We're going to bring in Grabzilla. Grabzilla is articulating, so it can reach up and grab. It's huge. It's for those really difficult jobs. Oh yeah. Look at that. It's all scar tissue. See how some of it's pink?
Yes, we
Hold
do.
it. Well, let's see. Even with Grabzilla, the laser is still a better tool, but sometimes the laser can't reach at funny angles. So you got to bring in rongeurs. That was helpful. You can see the effects of Grabzilla. My laser on, good. Of course, that piece of disc has to sit right where it's blocking my view. Give me the grabber. You piece of shit. A waste of my time. All right. Oh, you're kidding me. She's moving a little bit. God damn it. Are you seeing this, Bernda?
Yeah, give me a moment.
Mm-hmm. Right. Any questions from our audience?
No current questions.
Yeah, it's a painful disc. We've talked about this, remember? The outside is always more sensitive than the inside. And we always get to the outside last. All right, we're going to try Grabzilla again. Laser off. Scope off. No, don't move the scope. Don't push down. Just hold it. That should be a nice piece. And it is. Remember, removing a herniated disc is what we call a debulking procedure. You want to remove, take that? The other one? Yeah. You want to remove it in little pieces. Well, you want to remove the whole thing at once, but you're not going to get to do that too often. And it's not the surgeon's choice. It's the patient's body. There's a nice piece. It's just, you know, what we call the luck of the draw. Sometimes you get lucky, you'll get big pieces. Sometimes it just comes out in a lot of little pieces. So you have to be prepared for either possibility, eventuality. The last surgery we did today, the first one, that guy had some big pieces. This lady has a lot of little pieces plus a ton of scar tissue. Don't grab it. It's a pinch on the sides, not a grab on the top. Yes. Man, so many little pieces. You see them all just coming out? All right. Getting closer to being done with this side, but I think I'm going to have to bring Grabzilla in again. Now, Luis, you see this here? Okay, you don't push the tube down. Okay, look at the screen. Okay, watch what happens when you push the tube down. It goes down. I don't want it down, I want it here. All right, so just hold it in place, but don't push it down. Does that make sense?
Yes, sir. Yeah.
All right, I'm going to go for another Grabzilla in a moment. I just want to get as much of this loosened up with the laser as I can. Yeah, that looks like a really good bite right there. Right. Not bad. Still a lot of scar tissue. The nice thing is I'm able to reach up towards the herniation, and it feels like it's at least 60% gone, which is, I need 50% or more. 60% is better than 50%. So I'm happy with that. I'm going to probably go to the other side now. Huh?
About 2 minutes left here.
For me? Yeah. On this side, 2 minutes left. Laser. I just want to get some of these looser fragments out, and then we'll hit up the other side. any questions from our audience?
No current questions.
So I've really gone as much as I can at this point because I've pulled back as far as I can safely. We're starting to see some epidural fat, and just beyond that fat will be her L5-S1 nerve root, and that's going to be going down her left leg. So I really don't want to see that thing, but it's just hiding in at 12 o'clock. So far, everything's going very well for her. This is the lateral disc herniation that she has. It's not much. One more grab. That IV pole is back in my way. Is there any way you can lower the top just a little bit? Very nicely decompressed. Look at the movement we have. It's really good. Yeah, it's out of my way, thanks. I'm happy with that. There's no pressure on the nerve. I can see a gap there between the back of the annulus and the epidural space. One side down. Look at all the pieces here, guys. You see it, Henry?
Yes, we do.
Sanjay?
Yes, we do.
Like I said, in some patients, they all come out as one big, and others they come out in many little, and there's usually some combination for most people. A few big, a few little, but in general, it's usually 30 pieces per disc, if I had to guess an average. Come on, Jordan. All right, so I'm going to move to her right side. You ready? We like to hold pressure on the paraspinous muscle for a few minutes, just to make sure there's no vein bleeding. Yeah, sure. Shot. 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 I need to see, it's not bad, Jordan, but a little bit more. I would drop it just a little. Shot. So we gave a little more num-num. Now we're heading down to 5-1. Shot. Which leg bothered her the most? Anybody know? Equal. Shot. All right, at this point, we're just underneath the exiting root at 5-1, which would be your L5 root. Shot. Take. Tube. Impactor. Huh. Watch it. Shot. Want to keep an eye on your dilator tip. Make sure it doesn't advance into the pelvis. Shot. See how it moved forward there? You want to keep an eye on that, not let it go forward too much. Shot. Out. All right, beautiful. Good job, everyone. Now, I want to point out something. She is a very nice lady, very thin, not like thin, but good proportions. But look how much of the tube sticks out. We have some patients where the whole tube is buried completely. And we have others where it sticks out. So that just shows you where the spine is relative to her skin. And in her case, her spine is superficial. It's close to us, towards her back. Your tube would be buried, yeah. Mine too, probably. Well, you don't know where your spine's going to be. That's the thing. It really, being fat is one thing, but I've seen fat people where the tube is kind of posterior because their spine is posterior. You know? Congratulations. We got 10 minutes left by my best estimation. So I'm communicating as a surgeon with my anesthesiologist. I want my anesthesiologist to know how long I think the surgery is this part of the surgery will take till we're finished. It's his job to keep my patient sleeping, comfortable, but not to make them too tired, too sleepy with the medicine so that they don't wake up when we want them to wake up. Yep, thank you. Once again, on this side we have scar tissue. We have herniated disc. This side looks more recent in terms, look at that orange, look at that red there. That's granulation tissue. There's herniation. I'm going to have to cut this herniation because it all won't come out at one time. Any questions?
No current questions.
Fantastic. Once again, we know the story of this disc. It's going to give us a lot of little pieces. So we're just going to have to be patient and remove them patiently. The blue is the herniated nucleus pulposus. The white is the scar tissue. The gold is calcium or bone. Big tear. You guys see how big the tear is? It's literally top to bottom. Grab her. That's all herniation right there. So when you see me coming up, I'm coming out with just a piece of that herniation. So here's another piece. And I'm giving it to Luis. He's got a little, we call a Raytec or sponge in his hand, and he's pulling those pieces off. And then, you know, we'll do a little collection of them. Sometimes we'll do a group photo at the end. You guys see the pink color right there? That's granulation tissue.
Yes, we do.
got some great pictures of granulation tissue, Henry, don't we?
Yes, we do. I could do some screenshots and put it in our special cases folder if we need
Yeah.
it.
No, I don't need it for this one.
Okay.
This one, the granulation tissue is not as pretty as some of the ones we've done in the past where you can really see it nicely.
Understandable.
This one I think will just leave, unless I see it somewhere else, like really impressive. But right now, that's bleeding. That's not granulation. That's the difference though. The bleeding moves, like pours out. 5 minutes.
Doing very well.
Yeah, I think this right-sided herniation is a newer. Remember, her pain's been around for about 20 years. I think the left side has been around for a long time. Based on that scar tissue we saw on the left side, the right side I think has been around for a shorter period of time. So far, if you ask me, I'd have to say probably a couple of years, maybe 1 or 2 years. So it may be that she had the left from a long time and then she did the right recently. I may want Grabzilla again. Grabzilla is obviously named after Godzilla. And if you are a Godzilla fan like I am, it doesn't bother you to know that you've got a irradiated lizard to help you out in the operating room. Now, we could have called it a megalodon, we could have called it a T-Rex, but we chose Grabzilla. I did that to honor my mentor, Dr. Anthony Young, because that's what he called it, Grabzilla. Dr. Young is no longer practicing, but he is a very funny man. Stays involved. He's over 80 years old though. His son is taking over the biz, Chris. People ask me if I know Chris and Anthony Young. Of course I do. Chris went to school with me at UC San Diego undergrad. Then I went to USC for med school. He went to UCLA. Chris became an orthopedic surgeon like his dad, Dr. Anthony Young. I became a neurosurgeon. So we have a little bit different training, but we're both spine surgeons. And the difference is Chris has his father's dynasty to run. I'm creating a dynasty for my son and daughter at Duke Spine. It's funny because 20 years ago, actually, to be more precise, 17 years ago when I was trained on this technology, I saw the future with endoscopic surgery. And I think there are certain surgeons that understand that. But what surprises me is how many surgeons ignore it or decline it. They deny the truth about the future of how endoscopic spine surgery will dominate all of spine surgery. It's just a matter of time. Grabzilla. We're going to do a Grabzilla. It's clearly dominated my practice, and I've gone from being a fusion surgeon to being pretty much just doing endoscopic spine surgery. That's a good one. That was a nice one. That's all scar tissue, by the way. And it's not as bad as it was on the other side. It's just a little bit. The other side had about 10 times as much. All right, I think we're just about done. I want to grab a little more and then use the laser a little more, and then we'll be done. All right, any questions you have, feel free to ask away. I'll come answer them.
No questions, but we have a comment from Keynes25.
Sure.
It's a special day when Grabzilla gets unleashed.
Special day when what?
Grabzilla gets unleashed.
Yes. Yes. You are right. It's almost like a movie being made, right? I have to admit the Godzilla movies that have been made over the years have gotten, I think, good. Obviously, as a kid, I used to watch the old black and white Godzillas from Japan. But then, in the last 10 years, they've made some pretty good remakes of Godzilla, Godzilla and King Kong. I got to get a little more of that. I'm just about done. 3 minutes. Look at that, nice. So what a lot of you cannot see is that the water or the liquid that's going around in there is getting a bit cloudy. And the reason for that is all the pieces of disc herniation, they're actually coming out. Oh, come on, there we go. One more laser. And we call that a vaporization of the disc material. And it's possible because the laser literally dumps a massive amount of energy right onto the disc. Kind of like Godzilla, when Godzilla releases Godzilla's energy from his mouth right onto his enemy. And the enemies just absorb all that energy and then, well, suffer. So we're trying to make this herniation suffer so much that it wants to leave this poor patient alone. We're giving it some pretty compelling reasons to leave. But the energy gets absorbed by the proteins in the herniation, and then that breaks apart their, what are called their covalent bonds, which hold them together. 30 seconds. I don't really see much else. I just want to get as much of this as I can before I leave here. Remember, you're never going to get 100% of the disc herniation, never. So don't expect it. If you get 50%, the patient will do great. If you get more than 50%, hey, that's a good day in the operating room. Oh, so much scar tissue right here at the end. The more I remove of this area here, grabber. Actually, let's do one more Grabzilla. Nope. Endoscopic grabber. The scope on. Yeah. There's just nothing really left to grab. Just a little layer of scar tissue. But it's looking good, really good. Her back pain will be gone. Her leg symptoms should be gone. I think this went really well for her. All right, I think that's good. One more zap with the laser and we're done. I always try to do my best for every surgery, for every patient. Sometimes your best is really way more than what's needed. Sometimes it's barely enough for what's needed. But if you're always doing your best every case, then you know you did your best. You can't say, well, shoot, if I would have just done a little more, maybe the patient would have done better. So I think it's important to always do what you can, but don't go overboard and gild the lily. I don't know, Luis, there's something there, man. That bothers me. See that? I feel like I should be able to get more with the Grabzilla. I'm going to try one more Grabzilla bite. just not gratifying. I think it's just a little layer of scar tissue that's pushing up. It's getting away from Grabzilla, so there's no real mass effect to it. How are we doing on irrigation? That looks good to me. Yeah, that looks really good. I'm just getting a little greedy. So, what's happening, for those of you who are wondering, this stuff up here that I'm zapping, I'm taking away layers of it at the base of it by the disc side, and then the top stuff is kind of settling down. So it looks like it's refilling, but it's not. I mean, it was, but not anymore. All done. All right. Good job, everyone. I think she's going to be very happy with that. After all, that's what we're after, is a patient without back pain or leg symptoms. And one thing to keep in mind when you do get surgery like this, you know, I expect the pain in the back and legs to go away within a few weeks maximum. But the numbness from the pinched nerves does take up to a year to go away. Weakness can take up to a year. So weakness and numbness do take longer. But typically pain goes right away. Any questions, type them up. I'll come answer them. You can see this operative field here. We've got little pieces of herniation everywhere, like every which way but loose. You got them here. They're all over, you know. Here. You guys see this, Henry?
Yes, we do.
All these little pieces. What's your arm? Yep. All right, good job, everyone. I got this. You finished with that?
She did great.
Yeah, she did great. Remember, you got bilateral incision, okay?
Yes, sir.
Oh, it's easy to forget.
Thank you.
She needs some pressure here. Why don't you keep going, and I'll put some pressure for you. All right, type up your questions. I'll come answer them, but we're done for today. We only had 2 surgeries. Great job, my team. I think she's going to do great. You guys can go ahead and cut away.
Good morning, it's February 22nd, 2023. I'm Dr. Duke Mage, and I'm here with one of my patients who traveled to Duke Spine Institute, not too far away from Jacksonville.
That's correct.
Yep.
That's where we're from.
You found out about Duke Spine through the internet,
Yes, I did.
and why did you end up coming here?
I ended up coming here because I could not get rid of the pain that I had in my back and in my leg. I tried to exercise. I tried every physical therapy, yoga, everything you could think of, and I just could not get out of it. It just would linger and linger and linger, and it wouldn't go away.
How long have you had that back pain for?
This back pain has lasted me for the last 6 years. It started when I was working at the garden stores, doing a lot of heavy lifting. I took some time off from it, and then I jumped back into work, and the pain, just when COVID hit, I just had gotten a job in a garden, took another job in the garden store, and shot down my leg, and it's been like that. The pain's been like that for 2 years. So, you know, now it's 2023, and came here to see you, and yesterday we had it done, and in one day I'm doing a lot better now.
So you had the Duke laser disc repair done yesterday at L5-S1. You could see us in there with a tiny 7mm incision, the endoscope and the laser, cleaning out your disc. And clearly, to me, the disc did look injured, like they were about 5 to 10 years of injury. So it's been going on for a while for you. And you have degenerative disc disease. So a lot of people ask me, does the laser surgery work to get rid of back pain and leg pain when it's degenerative disc disease? What would you say? sitting here
It's-
now.
Yeah, I mean, my worry was that, the disc had gotten just so bad that it wasn't really replaceable, that, I was recommending a fusion.
Hmm.
And I certainly did not want that. When the pain came on, I researched and found you and said, no, I don't have to do that.
That's
I don't want
right.
to have to do that. That's just not right.
Yeah, so you have degenerative disc disease at L4-5, L5-S1, but you had back pain coming from them. We did the laser surgery, we didn't do fusion. Is your back pain still there?
No, it's
Gone.
gone. It's gone.
Yeah. And the pain in your right leg, down the back of your right leg, is that still there?
That's gone.
Gone. Now, is it gone because we put you on narcotic painkillers and you're loaded up on morphine right now?
Yep. No
No.
pain medicine, no anything.
So what did you take after the surgery? You took a Tylenol,
Tylenol,
Robaxin,
Robaxin.
and are you still
fact-
taking them or are you eating them?
I took them this morning. In fact, so I didn't even take them right after. Went to dinner after this, and yesterday went to the hotel, slept real well, and got back up. And
So no
things are looking
narcotics. You've been up
And-
walking around.
Yeah,
The surgery was
and
outpatient.
At 62, this is my time to really concentrate on my health and get back to the exercises and the walking I want to do, the swimming I want to do, the bicycle I want to do, the living, not the existing.
Exactly. Living because
Not
you're
ex-
not limited by
just
pain
more.
anymore.
Yeah, and maybe I was a judge was good. We did disability over the phone because of COVID, and he awarded me that.
Congratulations.
And that was 2 years ago. But I don't want to depend upon the government. I want to go out and get working again.
You may not need disability anymore. What do you think?
That's where I'm going.
I want to mention one more thing.
Sure.
You did have surgery already before you came to
And
me.
that's another thing.
You had laminectomy.
Yeah.
Did it work for you?
I have to say, it may have worked only because my first surgery, and I stopped the work that I was doing at the Jacksonville Zoo and Gardens. I'm a horticulturist, so.
But if it worked,
But it
you wouldn't be
be
here having
here
another surgery.
No.
So did
Because-
it work for you? Did it take away your back pain?
No, it didn't. Not in the long run.
Did it
No,
take
because it
away your
weakened the
leg
spine.
pain down your leg?
No.
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 So the problem with laminectomy is people feel good maybe for a little while, a few
That's
months,
right.
maybe a year, but then because they've removed all the bones and ligaments
That's exactly-
from your spine, it causes things to get worse.
That's
and they're
what-
not addressing the disc. The disc is actually the cause of all the pain.
Right.
And they didn't fix your disc.
No, because when I had that surgery, I stopped the job I was doing, took time off, and went back and boom, it went back in.
Okay, so as soon as you got active again, the pain came back.
That's right.
Yeah, that's the problem, is that you really just limited your activities rather than fixing the source of the pain. Laminectomy doesn't do that, doesn't fix the source of the pain. The Duke laser disc repair does. Well, congratulations. I'm
Great.
happy for you.
Great.
And I'm excited for you and the rest of
Sure.
your life. 62, you're going to start enjoying life and doing all the things you want to do. But remember to
Absolutely.
let it heal first, okay?
Yeah, we're gonna let it heal. And before I put that big heavy guitar on me, because I am a guitarist,
Of course, there you go.
So-
Anything you want to say to your musical fans out there?
just remember.
Well, I'm sorry to cut our testimonial short. We seem to be in the habit of doing that lately, but I have so much to tell you I couldn't wait. Anyway, the surgery went quite well for her. She is from originally Vietnam, and she told me she injured her back years ago, like 20 years ago. She's been living with back pain on and off, and then of course over the last year it's gotten permanently settled in. And what happens is you get the history where patients have back pain from a herniated disc. They get a tear in the annulus, they get a little bit of herniation. That herniation starts up some inflammation, and then eventually your body kind of puts scar tissue around it, and it stops it from being, painful. But then you go out and do something, some activity, and then you tear it again, because the tear has never really been cleaned out, so it can't heal properly. Anyway, this cycle of tearing and herniating and healing and tearing and herniating and healing is what causes this on and off back pain over the years. Same thing with the neck and thoracic. So her herniations over time got so big they were starting to pinch the nerves and irritate the nerves coming out of the holes right here called the neuroforamen, and that's the L5 nerve right there. So I went in through the back and we put a tube in like this. Hopefully you guys can see this.
Yes, yeah.
Right? We went through the natural opening there just underneath the exiting root, and I was able to clean out the herniation using the laser and the endoscope, and of course we had to bring in Grabzilla. But you can see the L5-S1, there's not a lot of space, so you can see how hard it is. The other discs are much easier. A lot of surgeons won't do 5-1 transforaminal, they do interlaminar. All right, but we're all done with the surgery and it went very well. So let's take a question or two.
This question just comes from Kit on YouTube, and they asked, "Hello, I watch almost all of your videos. You used to do DPR with the endoscope and laser for facet pain. What is the difference between the old way and the new way? And do you still do the old way?"
So great question, Kit. The DPR, Duke Plasma Rhizotomy, I do for the facet joint pain I use the plasma rhizotomy tool to kill the pain nerves to the facets. Before that, you're right, we did it with the endoscope with the laser. The problem was we just weren't getting as good a results. It wasn't as consistent. You couldn't really see the nerve, and the laser had to be right up against it to kill the nerve. So there's a lot of soft tissues, a lot of arthritis, bone spurs in the way, and basically we weren't getting great results with the endoscopic laser facet rhizotomy. So I just figured out a way to do it using an old technology that we had been around with spine surgery for years, but never been used in this way. So I took an old technology with a new application, and I gave birth to the Duke Plasma Rhizotomy. It works so well, it's so fast, it's so effective, there's no side effects. We've actually taken it, now we apply it to knee pain, so people with knees that are bad, hips, shoulders, SI joint, all of those things can be treated with it. It's incredible. There's no going back to the endoscopic laser facet rhizotomy, ever. There's just no way. The plasma rhizotomy is much better.
The next question comes from Kit once more, and they ask, the old way you mentioned about so you can see the nerve root better. The new way, you can't really see the nerve root, right?
Yeah, so great question. With the Duke Plasma Rhizotomy that we currently do, you can't see the nerve root directly. As a matter of fact, with the endoscopic treatment, we couldn't see it either. Let me see if I can get, here we go. So just to orient you, maybe actually I'll use a different model. Let me use this model. Sorry. Okay, here we go. So here you've got the spine unit, all right? And what we've got going on here, just so you can see, I'm going to rotate it to the back. You can see the nerve root here, okay? You can see it here. What we're doing is we're killing the pain nerve right here.
You bring it a little closer to the, yeah, there you go.
We're killing the pain nerve right there, where the transverse process meets the superior facet, right in here. So we're nowhere near the nerve root. The nerve root is further anterior, so we stay away from the nerve root. That's why you're not seeing it. We don't see it. We don't want to see it. We're not supposed to see it. Yeah, so great questions, though.
And that is it for questions.
Hope you have a great day. It's Thursday. We're going to be coming back on Tuesday next week for more surgery, but we are done for today. Probably a good thing. I need to go home and rest. Have a great weekend. Thanks for joining us.